All right, we'll go ahead and get started. Again, I'd like to welcome everybody to our webinar on Evaluation and Management Office Services. My name is Leanne Foster, and I am a Provider Outreach and Education Specialist here at WPS, and I'd like to welcome you and thank you for attending our session today. I do have a couple of housekeeping items that I do have to go over before we start the material today. First and foremost is going to be access to that training material. Training material is going to consist of the PowerPoint or the slide deck that I'm utilizing today, and that is available on our training center page and our live events page. Once you're there, you're looking for the title of today's session, you will see a link to the training material, which is going to allow you to download that PowerPoint. It is not a requirement for you to have that to continue in the session today. However, if you'd like that for your own note-taking purposes or to follow along, it is there and you will have that. We are taking questions through chat today. I did receive some pre-submitted questions and I have worked the answers to those into the material for today. So those of you that sent those pre-submitted questions, I thank you. But I will be checking in with Ashley for questions in the chat. Feel free to throw those in as you have them. I don't want anyone to forget their questions as they have them. I will be checking in as time allows. If for some reason we have more questions than time allows, I will be creating a follow-up document that I will send out to all attendees in this session so that we will make sure that you get those questions answered today. Also, your input is critical to everything that we do here at WPS with Medicare, and we want to make sure that we are offering you the education that is relevant to you and that is really going to make a difference for you as you navigate that this Medicare program. So after this session, you will be provided an opportunity in a couple of different ways to provide us with your opinion and your input on what you'd like to see in our education. So I encourage everybody to take a few minutes, and I thank you for that time to fill out a brief survey for us. It includes, tell us how we did, what you liked about the session, what we could do better about the session. However, this is also an opportunity for you to provide us feedback with topics that you'd like to see in our future education. We want to hear from you, and we really do look at all of these. They also help us improve our education. I do have a couple of disclaimers that I need to go through before we get started. This first one is our standard disclaimer, and it is just letting you know that the material that's been being presented today is accurate as of today. If you've worked with Medicare for any period of time, you do understand that Medicare changes, and it does change often. So I'm going to encourage you to continue to monitor official CMS communications, which includes the WPS website, listservs, just to ensure that you are following current Medicare rules and regulations. Also, CMS does strictly prohibit the screenshotting, photographing, or recording of this material for profit-making purposes. And as I mentioned, I have started a recording of this session. That recording will be available on our website on our Encore presentations page, where you can view that without accessing our YouTube channel. It does have an embedded player. Do understand that not everybody can access YouTube from their business computers. That will be available on our website for 60 to 90 days. After that, it will be available on our YouTube channel for as long as the material is accurate and relevant. I will be sharing with you some CPT and some HCPCS codes today. So because of that, I do have a couple of copyright notices to share with you. This first one is from the American Medical Association, and it's the copyright notice for CPT codes. It's just stating that the descriptions and other information regarding the CPT codes are owned by the American Medical Association and not CMS or WPS. And this next one is for the American Hospital Association, and this is because I will be talking about some codes that could be included on a UB04 or an 837I electronic transaction. Same thing here, just indicating that the American Hospital Association owns those codes and not CMS or WPS. Okay, that brings me to our objectives and our agenda for today. So what are we going to cover today? Our objective today is to help you with help you understand the rules for evaluation and management services that are provided for office services. So we're talking about codes 99202 through 99215, and we're going to be discussing these for the billing for professional services. So what are we going to include in that? We are going to talk about how you're going to determine if your patient is a new patient or an established patient. We are going to touch on how to identify bundled services. We're also going to talk about prolonged services, and included in that, I am going to provide an overview of the add-on complexity code G2211. Now, for some of these, we are going to be offering some more in-depth training, particularly for the G2211. That's actually going to be a session that's going to be offered here in July by Ashley, and that will go much more in depth than we will today. So if you're interested in more in depth than what we covered today, I do encourage you to check that out. It will be offered in July, and that registration will be opening soon. Also want to call out that this education is not going to be covering how to bill for facility charges. Professional charges will include rules for professional services that are being covered by rural health clinics, our federally qualified health centers, and our critical access hospitals that are billing method 2. The professional services and the documentation rules are still going to apply, so I will include some information, but we're not going in depth into those, the facility services for those today. As with many facets of our life, Medicare utilizes a lot of acronyms. I've often said that their acronyms need a Medicare to English dictionary. So what I've done for you today is I've included a list of acronyms that I will be utilizing throughout the session today. So to start out, I'm going to go over a few things that you need to keep in mind when you're billing for evaluation and management services. First and foremost is that the service must be reasonable and medically necessary. And what that means is outlined in the Social Security Act in Section 1862. And as you can see, I have provided a link to that if you'd like to look at that further. But to break it down, the services must be reasonable and medically necessary and not statutorily excluded. So the service has to be for the diagnosis or treatment of an illness or injury, or to improve the functioning of a malformed body member. That is what Medicare needs in order to allow the service. If it's not, Medicare is not going to allow it. What we're looking for medical necessity in the documentation, and this was part of the pre-submitted questions that we received, what we're looking for first and foremost is the service medically necessary for the patient at this time? And again, documentation is going to be key. If that documentation does not support that diagnosis or treatment for an illness or injury, or to improve the functioning of a malformed body member, then Medicare is not going to allow it. So we often get asked for examples of what this looks like. So one example that I can give you is you're seeing a patient to establish care. There's nothing to diagnose, there's nothing to treat. So then the question is, why is this medically necessary? If they don't have an illness, they don't have an injury, there's not a malformed body member, what's the reason for that visit? Why is it medically necessary? That needs to be in that documentation. In this example, there's not a diagnosis, there's nothing to treat. So in this example, it's not for the treatment and it's not medically necessary. Therefore, Medicare is not going to cover that service. So that's really what we're looking for medical necessity. Why was the service needed for the patient at that time? What were they being treated for? I also want to, the next thing to remember I want to call out is that E&M services are a per diem service. Medicare is typically going to pay for one service per day per patients. Now, there are going to be some exceptions to that, and we'll talk through those today. But you do have to remember that, and we'll talk about the definition here a little bit more in a minute, but we're talking about a per diem service. We're looking per patient, per provider, and same provider is going to be a provider of the same specialty in the same group. And again, we'll get into that in just a bit. There are exceptions, and those are pretty clear. So if there are two services that are on the same day, and they're unrelated and could not have had services provided for them, that treatment, that diagnosis could not have been provided at the same time, those are going to be situations where that per diem service is going to be an exception, and we may allow for 2 E&M services at the same time. There are some modifier codes that come into this, and we'll talk about those in a little bit later. But an example, often we get asked for those examples. So basic example, you have a patient that's seen in the morning for diabetes, and then they come back later in the day and they're throwing up violently, and they weren't when they were seen in the morning. They're complaining of stomach pains, again, which they did not have in the morning. In this case, the patient was not throwing up. They did not have those stomach issues in the morning, therefore they could not have been treated in the morning when they were seen for the treatment of diabetes. So that's just one example. Again, that documentation is going to be key. We need to see why it is medically necessary and why it's not something that could have been treated at the same time. You are also going to need to choose your level of service. As I mentioned, we're talking about the codes from 99202 through 99215. And the range indicates a particular level of service. So you can choose your level of service based off of the time that your practitioner spends taking care of that patient, or medical decision making, which is going to include that medical history and exam, and you're going to look at the problem or problems that were presented. You need to look at the amount and complexity of the data utilized and that was analyzed, collected and analyzed for that service, and you're going to look at the patient's risk factors. Again, you have your choice between time and MDM, and you're going to want to see which is most advantageous to you. So it could vary, and it may not be always that you're selecting based off of time. It may not always be that you're selecting off of MDM. You have to look at the encounter and see what makes the most sense for you. With time, I do want to call out that is going to include both face-to-face and non-face-to-face time that is spent on that patient. Next, I want to talk about the place of service codes that would be used for your providers that are billing those CMS 1500s or the 837P electronic transactions. So again, we're talking about the codes of 99202 through 99215. So 99202 through 99205 are going to be the codes that you're going to utilize for a new patient. 99212 through 99215 are going to be the codes that are utilized for an established patient. Now, the procedure codes, as I said earlier, that we're going to be discussing today are going to be applicable, not only applicable to the office, but they could also be for provider-based hospital. Now, we're talking about place of code 11 for an office, 19 for an off-campus outpatient hospital, and 22 for an on-campus outpatient hospital. Those are the places of service that you're typically going to use here. We do also allow for the place of service codes for telehealth. 02 is going to be when that service is provided somewhere other than a patient's home, and then, or the patient somewhere other than their home, and 10 is going to be when they're in their home. So you do need to make sure that you're utilizing these place of service codes appropriately. Now, as I mentioned, we're not going in depth into billing for services for the facilities. However, because we do have our rural health center providers, our FQHCs, and our CAWs, I know I have some of those in attendance today. I do want to give a call out to the type of bill that you're going to utilize. Those services are going to be billed on that UB04, that 837I transaction. So versus a place of service, you're going to be using the type of bill. And here I have listed the 13X for an outpatient hospital. That's 71X for an RHC, a 77X for the FQHC, and an 85X for a CAW. So things to keep in mind when you're billing for those services. Now, I mentioned determining new versus established patient. So when you're talking about new versus established patient, I do need to start with what Medicare considers the same physician, as I mentioned earlier, because it does impact new versus established patient. And this seems to be a question that we do get often. So Medicare views the same person or the same provider as the same a provider of the same specialty with that same group. So let's break this down a little bit. Same physician is same physician. If you saw the same physician in the morning and you saw the same physician in the afternoon, that's same physician. Same specialty. So same specialty has to do with the 2-digit specialty code that the provider designated themselves as for their primary specialty when they enroll in Medicare. They have to designate their, for instance, internal medicine. So we're looking at that 2-digit specialty code that they were enrolled under. For the mid-levels, for nurse practitioners, physician assistants, I do want to call out they are not automatically set up as the same specialty as the physicians, say in internal medicine. Nurse practitioners, all nurse practitioners, regardless of the area of discipline, maybe they're in cardiology, maybe they're in internal medicine, they're not designated that way. They are designated with specialty code 50, which is nurse practitioner. Physician assistants, for example, are 97. All nurse practitioners, all physician assistants, all non-physicians, depending on what they are, will have that same specialty. And I point that out because we're going to talk about that a little bit. It can be a little problematic if you have somebody who sees, say, multiple nurse practitioners in different disciplines, maybe an internal and a cardiology nurse practitioner on the same day. We'll talk about what to do when that happens. But I want to call out that those mid-levels, those nurse practitioners, for instance, are not automatically under the same umbrella as the physician they work for. I also want to call out that when Medicare processes claims, we're processing using that primary specialty. For physicians, they can declare a secondary, and I've even seen, I have some provider enrollment background, I've even seen where they declare a tertiary or a third specialty. We're paying off of the primary. So it's also going to be super important that when you have your providers set up for enrollment, or if their specialty changes, that you're updating that information, because if they're set up under the same specialty as another physician that saw the patient, but they shouldn't be, that's going to potentially cause claim denial. So you want to make sure you're cognizant of that. The other piece of this is that that same provider of the same the provider of the same specialty is in the same group. Group is identified by that tax ID. Groups can have more than one NPI or National Provider Identifier. So sometimes that can differ based on practice locations. So we want to make sure that we're looking at that same tax ID. So to be a new patient, what does this mean? So to be a new patient, there have to have not been any other services that were considered as the same physician from the same group in the previous 3 years. So that means there's not been a professional service from a member of the same group with the same specialty in the previous 3 years. And this includes other E&M services, so other office visits. It could be surgical procedures. It could be a cardiology service that requires a professional's presence. So you have to look at what has happened. You want to look at what else would count as a professional service. So a couple of examples. So if you have a doctor that saw a patient 2 years ago as a member of a different group, when the patient follows that doctor to a new practice, that doctor has to bill that as a subsequent visit. That patient was already seeing that provider in their previous practice in the last 3 years. Because that doctor changed practices and now works for a different clinic, does not make the patient new to that provider. Another one, if you have a provider that's performed an emergency surgery on a patient, say 2.5 years ago, this is a professional service, so that's going to fall into the previous 3 years. So you want to look at that. So I want to come back to the non-physicians just a little bit. I mentioned that, for instance, nurse practitioners and physician assistants, they all have the same specialty regardless of what their scope of practice is. So one of the things that you're looking at there is who saw the patient that day. We do have instances where a patient will see multiple nurse practitioners, one for internal medicine, one for cardiology. When those get billed, we will see where we'll have 2 new patient visits billed and one gets denied because we've already paid for one. If they're under different, I don't want to call them subspecialties because we don't set them up that way. But if you have a patient who's maybe having multiple visits, just to make it easier on the beneficiary, you're going to want to bill for those nurse practitioner or physician assistant visits to include in the narrative the specialty in which their scope of practice is. So again, internal medicine or cardiology. If you do that, our system is set up to recognize those nurse practitioners or physician assistants as different specialties. We will talk about that a little bit more a little bit later, but I want to call that out now. Next, we're going to talk about procedures that happen on the same day as an E&M. So E&M is reimbursed as part of a procedure when there is a surgery. It's included in the reimbursement for that procedure if it has a global period. So you can look at the Medicare physician fee schedule or that relative value file to determine whether or not there is a surgical global period where that E&M is already considered paid as part of that service when performed by the same provider. Now, there are some exceptions to that. Modifier 25, this one tends to be a bit of a struggle for people. It can get kind of complex and there's a lot of misunderstandings. We are going to be offering a webinar that is going to be specific to that. That'll include some clinical staff that you may want to look for. We did offer it recently. There were some technical issues with the recording, so we are going to be offering that again. If you'd like to take a deeper dive into this, that will include some clinical examples. But for today's purposes, what we're going to talk about is going to be the definition of it. And the definition of it is that it's a service that is significant and separately identifiable from the procedure. So that means that the documentation has to support, if you're using this modifier 25, it has to support why that service was a significant amount of work over and above what is normal for that procedure that is being billed along with or on that same day. So we need to have a reviewer, or a reviewer needs to be able to see what additional work is included that is making that a separately billable E&M service. So it has to be very clear. One thing that we do see is that sometimes we're showing modifier 25s are being attached to every E&M. That's an inappropriate use. Okay, so again, this 25 is when that E&M is being billed on the same day as another service. So an example of appropriate use. You've got an E&M on the same day as an annual wellness visit. Modifier 25 could be appropriate. Again, we have to see why it's significant and separately identifiable from the other E&M visit that's being billed on that day. An inappropriate example is going to be if you have an E&M that's billed on the same day as a chest x-ray. In this scenario, that chest x-ray isn't something that's part of our National Correct Coding Initiative. It's not bundled with anything, and it doesn't have a global surgery period. So in that case, both of them could be billed without a modifier 25, but we do see where those codes do come in with a modifier 25. So make sure that you're looking at that relative value file or the physician fee schedule just to see whether or not modifier 25 is appropriate for the codes you're billing or your scenario. Couple of suggestions, things that we've seen. See if your system is automatically adding modifier 25 to all E&Ms. If it is, someone needs to take a look at that and see if that makes sense. I can tell you it shouldn't be added to every E&M that's billed. It needs to be added again when the E&M being billed is on the same day as a service where it would have been bundled in, has a global period, and it has to support why it needs that separate payment. So take a look at your data, do some data analysis, see what your data is telling you, are you utilizing modifier 25, or do some adjustments need to be made? Next is modifier 24, and this one is fairly straightforward. What modifier 24 is that it is for an E&M that is not on the day of the surgery, but during the global period or surgery days for procedure, and it is unrelated. So modifier 24 is not going to apply on a procedure that has a 0-day global period because that's the day of the surgery. It would apply to anything with a 10 or 90-day global periods because, again, we're talking about it being unrelated. And in that documentation, we are going to need to see whether or not that E&M is related to that surgery, okay? So an example, you did a repair of a laceration with a global period of 10 or 90 days. The patient is now back with the possibility of COVID. So this is not related to that laceration repair that happened. So that would be where you could apply that modifier 24. We also received some questions about modifier 57. So modifier 57 is the practitioner's decision for a major surgery. So this is going to be a surgery with a 90-day global period. And it's a decision for that major surgery on the day of or the day before the major surgery. So you're deciding that they need surgery now. We're either doing it today or we decided yesterday we needed to do it. So the things to remember there is that it's major surgery. So we're looking at that 90-day global period. You've decided, as I said, that the surgery needs to happen today or tomorrow. And it's likely going to be a more urgent or emergent type of a surgery. So you're not going to use this if you're deciding in August that you're going to do, say, a hip surgery in November. Okay, that's not the day before or the day of the surgery. You're making the decision for surgery in August. Now, if you see the patient again in November, which is when you're going to perform that surgery, that's not the decision for surgery either. So it's not going to be applicable there because you made that decision in August. You do need to look at your documentation, and that documentation does need to support when that decision for surgery was made to identify whether or not modifier 57 is appropriate. We do see some questions come up often with the administration of a drug. So for the most part, an E&M is going to be part of the administration of that drug, and that's going to include both diagnostic and therapeutic drugs. If your clinical staff is administering that drug, you're not going to be able to bill also the 99211. That's not separately payable because that's all included in that E&M. Now, if you have a practitioner who is also seeing and evaluating the patient for a higher level of service, maybe there's something that is unrelated or it's significant and separately identifiable, then that documentation needs to support, and you may be able to apply a modifier to that, for instance, possibly a modifier 25, but it's not a one-size-fits-all. You really need to look at the documentation. We need to see the proof of thought, and we need to have that documentation demonstrate why that modifier was needed. And I do want to point out with this, we are not talking about a surgical procedure for an injection, such as an injection to the joint. This is going to be maybe an IM injection or an IV injection, something like that. So I've mentioned NCCI a minute ago. I mentioned that when I was talking about some of the modifiers. So I want to talk a little bit more about that. Again, this is a course in and of itself, and we do have YouTube videos out there that do talk about NCCI. So we're not going to go super in depth with it, but I do want to talk about it at a high level and how it's going to impact your E&M services. So this is a picture. What you're seeing here, it's a couple of snapshots of the NCCI columns, and it's showing how an E&M can be a column 1 code, which is the payable service. It's also showing how an E&M service can be a column 2 code, which would not be payable. unless a modifier is appropriate, because it is bundled into another service. So kind of goes with that global surgery that we were talking about earlier. Here you can actually see, if you look on what you're seeing, the first image is going to be just the top, and it kind of defines the columns, which we're going to talk about in a minute. On the right side, the top image, what you're seeing is that 99212 is actually a column 2 code there, and it's actually bundled into that column 1 code. Now, the bottom image is going to be the 99212, where it is the column 1 code, and it is going to be payable. So you want to take a look at these before you bill, and it'll let you know whether or not something is bundled. This slide is running through the definitions for those columns. So column 1 is always going to be that payable code. Column 2 is going to be the bundled code that is part of that column 1 code. Column 3, this you probably are not utilizing often, but it's going to let you know if it was in effect prior to 1996. That may apply to your situation. It may not. Column 4 on that chart is going to be the effective date. So when this NCCI edit, it was effective. If it's discontinued, it will show you that in column 5. Column 6 is going to be your modifier indicator, and this is going to be that key part to those modifiers that we just showed. You're looking for a 0, means that a modifier is not allowed. A 1 tells you that a modifier is allowed, and 9 means that the concept does not apply. So it's not something that you're going to utilize. And then column 7 is the reason for inclusion. One thing that I did want to show, so here's an example of that list that you're looking at on that screenshot. One question that we've gotten would be for allergies. So here is an allergy procedure code. That is the column 1 code that is payable. It has the 99211, and it has a modifier indicator of 1. So this is the date, and then it's showing you if it's in effect. So it has a 1, and here it is showing that a modifier is allowed in that instance. So that is just an example of how you'd read through that. And that's available. We have included a link in your resources section to where you can access those lists for the NCCI edits. Next, we're going to talk just a little bit about Incident 2. This is something that we do plan on offering a deeper dive into later this summer. But at a high level, I do want to talk about what the key criteria and requirements are for this. So first and foremost, Incident 2 is for office location. So that's going to be that place of service 11. This is not going to be something that facilities are going to be eligible for. So those place of service 19 and 22, that is going to be where split shared will come into play. We're not going into split shared today. That's also something that we will be offering an event specific to split shared later on this summer. So keep an eye out for that. So again, Incident 2 is for place of service 11. The next key criteria is going to be that there needs to be an employment relationship, meaning that the staff providing the service must be employed by the billing practitioner or by that same entity. This employment relationship can be established a lot of different ways. One of those, it could be a W-2 employee, so they're a direct employee. They could be a 1099 contracted employee. They could be a leased employee. Again, there just needs to be that direct employment relationship to be eligible for those Incident 2 services. Now, Incident 2 services also must be incidental to the patient's plan of care. So the plan of care is going to show that these services are being provided by the clinical staff or those non-physician practitioners under that plan of care from the billing practitioner. Okay, documentation is going to be key here. And when you're submitting that documentation, Also submit the plan that's showing that the nurse practitioners or the non-physician practitioners and clinical staff are following that original plan of care. It needs to be clear. What can happen is the oh by the ways. What can happen is that patient can be coming in and receiving treatment from that clinical staff or that nurse practitioner for that plan of care, and say the nurse practitioner is leaving the room and oh by the way, they have a rash on the elbow. They weren't coming in to be treated for that rash on the elbow. They're being treated for something else. So at that point, nurse practitioners can evaluate and treat patients. So at that point, that's no longer following that established plan of care. And so that's not going to be billed as incident 2. Once they are deviating from that established plan of care, that in this instance, that nurse practitioner needs to be enrolled and will be billing for that service versus billing underneath incident 2 guidelines. So again, documentation is going to be key there. Next is going to be direct supervision. So that direct supervision is going to be from that billing practitioner, and they're in that same office suite. And we do get questions about that. What does in-office suite mean? We had a medical director that defined that once as speaking loudly distance. So they're in the same suite. They're not on a different floor. They're not in a different building. They need to be immediately available should they be needed. You can also provide supervision by audio or video communication. There are some waivers where appropriate. We're not going into all of those services where that's appropriate, but it is something that you do need to look at when you're billing for incident 2. So what will happen is the documentation is going to need to be signed by that billing provider. And that is because they have created that plan of care and they're signing off on the services that have been provided. So make sure that that is being appropriately signed and that that documentation is clear regarding those incident 2 services. I mentioned split care services, incident 2 services not being a possibility for facilities. The reverse is true. Split shared is not available in an office setting. So that's really one of the big differences. Incident 2 is for an office setting, and that split shared care is going to be in that facility setting. Next, we're just going to touch on prolonged care, and that is going to be code G2211. So to use this, you do need to be selecting your level of service based off of time, not MDM. So if you're selecting your level of service based off of MDM, this is not something that's going to apply to you. But if you are choosing that based off of time, you could potentially bill for the prolonged service. We are going to be offering a session that goes a little bit deeper into these, but I wanted to include this today so that you have it because I know it does impact office services, and we did see some pre-submitted questions on that. So as I said earlier, the time can be both face-to-face and non-face-to-face time. You do need to document that time, and while we do not expect providers to use a stopwatch on themselves, the time does need to be accurate. So they're not providing a range. They're not saying I provided approximately 30 to 60 minutes. We do actually need to know what that time looks like. And again, I'm going to say this a lot because we do find that providers forget this. Make sure you're including both face-to-face or non-face-to-face time that is spent on that patient. You don't want to leave any money on the table there. So here, what you're looking at is a chart that is in the Medicare Claims Processing Manual. And this is where things can differ from the Medicare Claims Processing Manual from CPT. So in order to utilize G2211, you do have to meet a full 15 minutes to bill G2212. And that full 15 minutes has to be above the highest level of code. So here we're including the chart so that you can see what that looks like. So if you provided, say, in this case, we're going to say the 60 to 74 minutes, even though you're above the highest level for that 99205, you're still just billing that 99201. Once you get to 15 minutes above the time allowed for 99205, then you can bill for G2212 or 1 unit. And then for every additional full 15 minutes, you could bill an additional unit of that G2212. So again, this is only if you're selecting your level of service based off of time. And as I stated, this chart is available in the Medicare Claims Processing Manual, Chapter 12. Easiest way to get to it is to search for prolonged codes, and I have included a link to Chapter 12 in the resources for today's session. Here we're going to talk just briefly, as I mentioned earlier, about G2211. Again, later this summer, Ashley's going to be offering a session specific to G2211, and it's going to take a deeper dive into that. So if you're interested in that, that's something you want to take a look for. But this is an add-on complexity code, and this code is something that is allowing for additional payment because of the long-term relationship a provider may have with a patient and the additional work that's involved in coordinating their overall care. So the providers who can bill this code have to have a longitudinal relationship, pardon me. They have to have a long-term relationship with the patient or they're treating a single serious or chronic condition. So this could potentially be billed by multiple providers. It's not necessarily just going to be billed by one provider. And this is a relatively new code. We've been billing, this has been a code for about 1.5 years. So it started at the beginning of 2024. And what we're looking for is that the practitioner would be addressing the majority of the patient's health needs. So they're either dealing with a specialty condition or that patient's overall health. So like I said, this could be a situation where more than one of the patient's providers are billing for this. But the documentation does need to support that longitudinal relationship. So it does need to support that they're the focal point of the patient's needs, or that they're overseeing ongoing care for that patient's single serious condition, or maybe there's a complex condition. So it isn't something that you need to have a certain amount of time that you've already been with that patient. It's something that we need to know you are going to continue to be that focal point. Again, that documentation is going to be key. We need to be able to establish that relationship. Now, if you do have a patient where it's a short-term situation, you're maybe treating a minor condition, you're seeing them once or twice, that's not going to be that long-term relationship. So another part of or another add-on code for E&M is going to be office visits that are including risk assessments for their social determinants of health. So this gets confusing. There's the risk assessment and there's a screening. What we found during COVID is a lot of providers, with obviously the challenges of the pandemic, a lot of providers that maybe hadn't already were adding a social determinant of health screening to their visits, which is great, but that is different from this procedure code. So the screening is one thing. This is the assessment. So the assessment is where you have identified a social determination of health that is going to affect the medical decision-making for that patient. So your physician or practitioner is making changes to their plan of care based on the results of that risk assessment. This could be, maybe they have housing insecurity, maybe there's food insecurity, they have transportation needs that need to be addressed, maybe they have utility difficulty. By utility difficulty, perhaps you're prescribing insulin that needs to be refrigerated, and maybe they are having trouble with the electric bill, and if that refrigerator is not running, that insulin is not going to they're not going to be able to store that insulin properly. So before we start checking in for questions today, I did want to share with you some claims data that are specific to E&M visits for office visits. show you the kinds of denials and rejections that we see. Some of the pre-submitted questions that came in were about what those denials and rejections are, how do we avoid those. So as we look at this data, I pulled the data from February 1st of 2025 through April 30th of 2025, and I isolated office procedures for both new and established patients. And we are going to look at unprocessable claims, which is also known as a rejected claim, and denials. So we'll start with new patients. So these are going to be codes 99202 through 99205. So on the left side, you're seeing a list of the most common rejections or unprocessable claims for new patients. The first one is going to be that the claim is missing information that is required in order to process that claim. It could be missing a diagnosis. It may not have the provider's information on that. Without that information, maybe it doesn't have a CPT code. Without that information, we can't process that claim. So it doesn't actually begin the process because we don't have the minimum necessary information in order to look at that claim. So that's what that reject is going to be. We do also see quite a few rejections for rendering physician issues. So what this means is that, as I said, the provider number could be missing. It could reject for that under both of those categories. So maybe that rendering physician information is missing. Maybe it's incorrect. Check for a typo. We're looking at those MPIs. That's what they're billing with. We need to make sure that we have that right information. Could also be that they're ineligible, meaning they're maybe not enrolled. You can't bill for a provider who's not enrolled in the Medicare program and in the jurisdictional state. We do see this. I mentioned I have a provider enrollment background. We do see providers that might be enrolled in states where a city is in two states. This happens with some of our Missouri providers where there's a city that's across two different states, and they're enrolled in one state but not the other, and they're providing services in the state they're not enrolled in. When that comes in, that's going to deny. Also, for rejected claims, we see field 11 is not complete. So in field 11, the provider needs to state whether or not the patient has other insurance, is Medicare primary. So that either needs to indicate who that primary insurance is, or it has to say none or NA. Blank can cause a claim to reject. It is a required field. We need something there. Now for new patients denials, you could have multiple initial visits, and we talked about that with particularly with those non-physicians, nurse practitioners, physician assistants. 2 initial claims come in. They saw a nurse practitioner for internal medicine and a nurse practitioner for cardiology. They both have a nurse practitioner specialty. It looks like it's multiple initial visits on the same day by a provider of the same specialty in the same group. This is where, again, the claims can be submitted with their focus of practice or scope of practice, internal medicine, cardiology, in the narrative section of that claim. This is something that WPS looked at because we were seeing a lot of denials and a lot of appeals coming in for this. So January 1st of 2025, a change went into effect that allows those non-physician practitioners to list that focus of practice as far as specialty in the narrative section. That will allow our claims area to distinguish between 2 providers that are both either a nurse practitioner or a physician assistant. And it only applies to those 2 non-physician specialties. But it should help reduce some denials that are coming in. Otherwise, it would have to be appealed. Other denials that we see is 1 service per day. Remember, we talked about E&M visits typically being a per diem service. So we need to look at that and see if it's a situation where multiple, maybe that modifier 25 applies, maybe 57 or 24 applies, but you've got to look at that documentation. Maybe a modifier was omitted. We do see duplicate claims where claims are being billed every couple of weeks or maybe every 30 days. You do have to allow those claims to process. Don't just bill them every week. you'll end up with a lot of duplicates, and that actually kind of clogs up our system as well. Also, Medicare secondary payer, there may be a primary insurance that needs to pay primary to Medicare, so make sure that you're checking for that primary insurance and billing appropriately. And then also we see timely filing. Timely filing is 1 year, so make sure you're looking at that date of service. Now, for established patients, we are going to see a lot of similarities here. For instance, for non-processable, we do see that the claim is lacking information that's needed in order to process. Same thing with the rendering physician, missing, it's ineligible, it's incorrect. Check for typos, make sure that the provider numbers, that performing provider is correct. We do also see patient eligibility issues on established patients. So I would encourage you to use our secure portal to make sure that the patient is eligible for the service that you're billing. Also, are they eligible for Medicare? Make sure you're asking your patient those questions and make sure that you're not billing for services they're not eligible for. Again, that field 11 is not complete. That comes up. For denials, a lot of the same things here as well. Duplicate service, provider eligibility. Some services require particular specific specialties to provide them, so make sure that you're checking and making sure that you're billing appropriately there. The one service per day, Medicare secondary, and again, that timely filing. For the sake of time, I'm not going to run through those again, but they are as we discussed with the new patients. Here I have included resources, as I mentioned throughout the presentation today. I did include the Medicare Benefit Policy Manual in Chapter 15. I have included the National Coverage Determinations Manual. There's some great information there. Chapter 12, we did get some pre-submitted questions on whether or not there was a reference specific to evaluation and management services, and there is. CMS does have a Medicare Learning Network product that's available that is specific to evaluation and management services and includes a lot of what we talked about today. So you have that for reference. And then here I did include our playlist for some of our videos, but I also included some information specific to those NCCI edits, the files themselves, so that you can see where your code that you're trying to build, that A&M code you're billing, lands, whether it's a column 1 or a column 2 to help you out there, along with the policy manual. All right, we are running short on time, but I am going to check in and see if we have time for a question or two from Ashley. Ashley, do we have anything in the chat?
Hi, Leanne. We do have some questions in the chat. Let me just get back up to where these started coming in. And the first one that came in, I did provide an answer to, which was, how should we choose which level of service if both time and MDM are documented and each is a different level? To which I responded that you would choose whichever is most advantageous for you. There is a follow-up for that. That is, does advantageous mean whichever pays more, or can it also mean whichever is administratively advantageous to us? For example, if time would code as 99213 and MDM would code as 99214, will we be in trouble for undercoding if we bill 99213?
So when I say most advantageous to you, it is which one makes the most sense for you, but don't leave money on the table. So you're going to want to code for the work that you did. You should be reimbursed for the work that you did. I can't provide the coding advice to tell you which code you should bill, but you have to make that business decision of which one is most advantageous for you. And again, as I said, don't leave money on the table. With that, and I apologize to everyone, we are running short on time, so I do need to wrap this up. However, with the questions that are in the chat, I will be grabbing those and I will be providing a follow-up document that's going to include all of those questions and those answers that unfortunately we did not get to today. I did try to design the education around pre-submitted questions, so hopefully you were able to get some answers to those questions. But again, as I said, I'll send that out to all attendees for the session today. So to be respectful of everybody's time, I'm going to go ahead and wrap things up for today. So in a few minutes, you are going to receive an email that is going to thank you for attending. Don't delete this without looking at this. I know I saw from the pre-submitted questions, some are attending for continuing education credits. WPS does not issue those continuing education credits. However, our sessions do qualify and count as contact hours for you to submit to your accreditation body or certification body. So this email is going to serve as proof of those contact hours and your certificate of achievement. It's going to have a couple of things. It's going to have a link to the survey for you to provide some input, but it's also going to have those contact hours and the date. If you did not get this, one of two things happened. Either it went to your junk and spam folder, so you may want to check that, or you attended by phone and I don't have a way to systematically confirm your attendance. In either situation, in a few minutes, Ashley's going to put that email address in for our education mailbox. You can send an email saying that you attended by phone or you did not get a certificate. Include the telephone number that you joined by. I'll manually confirm your attendance and I'll be able to send out that certificate for you. As I stated, I am sending up a follow-up document with all of the answers to the questions that we did not have time for today, but you can also continue to send in questions for the next 7 days by sending an email to that education mailbox. In the subject line, you do want to include the topic of today's session, which is Evaluation and Management Office Services. That's going to let the individuals that are monitoring that mailbox know they need to get that to myself and Ashley so that we can get a response to you. A couple of ways you can do it. Obviously, start an email, put that email address in and put the subject line in there. Try to make it a little bit easier for you. If you have the material for today and you click on that link, it will open up an email that already has that subject line in for you. If you do have questions, though, that are specific to a claim that is in process, those do still need to go to customer service because they have the systems available to look up that information. As I mentioned earlier, your opinion matters to us. It is how we improve our education. It is how we know what education to offer to you. So I'd like to encourage you to take a few minutes now to tell us what you thought. Tell us what you liked, what we could have done better. And again, those topics for the suggestions for future topics. There's a couple ways you can take that. Ashley's going to or has already put a link in the chat. Click on that. It'll take you to that CMS Qualtrics survey. You're also going to get a redirect as you leave today's session. That's not malicious. That's not spam. That's not taking you anywhere you don't want to go. It's just letting you know you're leaving our webinar software and you're going into that CMS Qualtrics survey software for you to take that. So again, I want to thank you in advance for taking a few moments to provide us with a little bit of feedback. And there are outcomes to that feedback. So we do hear you. One of the things we want to make sure that you understand is that we are making changes to improve your educational experience based on that feedback. And I wanted to highlight a couple of things. This session was recorded and is going to be posted on YouTube. We are including chapters, and that is meant to allow you to more easily navigate to maybe key points within the videos so that you can get to the information you're looking for more quickly. The other thing you'll see as you register for events, I did mention a couple today, is we do have training indicators. So as you're looking for future educational events to attend, take a look at those training indicators. There's a link to the definitions out there for you as well to help you dial in on what sessions might make the most sense for you. With that, that does end our session for today. On behalf of myself, Ashley, Tom, and everyone on the the WPS Provider Outreach and Education team, I want to sincerely thank you for taking the time to attend today. We know we are all super busy, and sometimes taking this hour, carving this out to attend this session can be a challenge. So again, we look forward to your comments and I appreciate you taking the time to attend today. With that, that ends our session. You may now disconnect. Have a great day.